thank Dr. Ramraj Garu for giving me this opportunity today. Relationship between fibroids and infertility is still a dilemma to the gynecologists because till date there is no clarity about which infertile woman benefits from myomectomy. In this brief talk today, I will try to highlight the systematic review results conducted recently. Why are we so unsure about this relationship? Because as we all know, uterine myomas are heterogeneous in their composition, size, location, and number. And variation in any of the above factors can possibly alter the woman's fertility. A number of studies have been conducted till date, but all showed varying results. Although epidemiological studies are inconclusive, clinical evidence supports the notion that fibroids interfere with fertility. How often do you find them in infertile women? Usually they are seen in 5 to 10% of the infertile women, but surprisingly, they are the sole cause for infertility in only 1 to 2% of the cases. And several mechanisms have been put forward to explain the effect of fibroid on infertility. They are interference with gamete transport and implantation failure. Interference with gamete transport could be due to enlargement and deformity of the uterine cavity, uterine contractility, distortion of the cervix, and distortion or obstruction of the tubal ostia. And you can see in these pictures multiple locations of the fibroids interfering with gamete transport. Here is a submucosal fibroid altering the endometrial cavity, and a cervical fibroid distorting the cervix completely, and an ostial fibroid obstructing the tubal ostia. And this MRI picture shows multiple fibroids with enlargement and distortion of the uterine cavity. Moving on to implantation failure. Implantation failure could be due to endometrial contour alteration, vascular disturbances, inflammation, vasoactive substance secretions, and persistence of intrauterine blood clots. But none of these have been proven. All are hypothetical. In 2001, a systematic review of controlled studies was conducted by Elizabeth and Pritz, and they concluded in their study that submucous fibroids do have an effect on fertility, and removal of these fibroids improved the fertility in these women. After 8 years, the same authors repeated the review, and 23 studies were reviewed this time, and they tried to look at the problem in the form of 2 questions. They are, do uterine fibroids of specific size, location, and number decrease fertility? Enhance this fertility. And depending on the location, as we all know, they categorized them into submucosal, intramural, and subserosal. And the evaluation of the outcome was expressed in the form of implantation rate, clinical pregnancy rate, spontaneous abortion rates, ongoing pregnancy rates, and preterm delivery rates. I restrict myself to implantation, clinical pregnancy, and spontaneous abortion rates in this talk. In their report review, they said that submucosal fibroids have low implantation rates, low clinical pregnancy rates, and very high spontaneous abortion rates. Whereas in case of intramural fibroids, they are inconclusive because when they looked at the analysis of prospective and retrospective studies, they showed low implantation rates, low clinical pregnancy rates with high spontaneous abortion rates. Analysis of the only prospective studies showed low implantation rates and high spontaneous abortion rates, but there was no difference in clinical pregnancy rates. Analysis of the high quality studies showed different scenario. Here, there was no difference found in clinical pregnancy rates and no difference in spontaneous abortion rates. They could find an association only between implantation rates. The implantation rates were very low. Some authors of the opinion that fibroids from the inner myometrium distorting the endomyometrial junction have poor reproductive outcome, and fibroids from the outer myometrium, which cause just displacement of the endomyometrial junction, not distortion, have better outcome. And in their review, they expressed that No significant association was established between the size and effect on fertility. Some studies looked at IVF cycles to establish an association between fibroids and infertility. Here, tubal and male factors were excluded, and by transferring same quality embryos, they tried to see the influence of fibroids on implantation. And most of the cases were evaluated in their studies by ultrasonography, sonohysterosalpingogram, MRI, and hysteroscopy. I'm not going in detail about all this because already this is covered by Dr. Suman. And you can see in this picture by ultrasonography, you can identify the fibroid. And with the advent of 2D and 3D, we can also assess the involvement of the endometrium with the fibroids. And coming to the sonohysterosalpingogram, this is best suited for submucosal fibroids because you can see the extent of protrusion of the fibroid into the endometrial cavity. You can also differentiate an endometrial polyp from the submucosal fibroid. An MRI is the diagnostic test for fibroid mapping, and this is best suited before proceeding with surgery. And one thing we must all remember is we need to rule out other causes for infertility before blaming fibroid. And coming to the management, as we all know, expectant management, medical and surgical treatments. But one thing here is the medical management is not effective in improving fertility. Surgical approach is indicated when the fibroids are distorting the uterine cavity and fibroids of more than 5 centimeter size and multiple fibroids. Location and size of the fibroids are the major determinants in making decision about the type of surgical approach. And approaches are, it could be by laparotomy, laparoscopy, and hysteroscopy. No significant difference was noted in pregnancy rates when laparotomy and laparoscopic approaches were compared. And laparoscopic myomectomy, it's still a debated operation in terms of feasibility, indications, and risks. And the universally accepted indications are submucous and intramural fibroids, distorting the uterine cavity, and maximum size not more than 8 centimeters, and the total number not more than 4. And the reasons they quoted for avoiding myomectomy are because of their complications like significant morbidity associated with it, like infections and damage to the internal organs, blood transfusions and risks associated with it, and post-operative adhesions, especially so in case of posterior wall myomas, and uterine rupture during pregnancy, and increased incidence of cesarean sections, and the recurrence. As you can see in this graph, the recurrence rate of fibroids after myomectomy at the end of 5 years is somewhere around 10%, and the end of 10 years, it is between 25 to 30%. Coming to the hysteroscopic resection, this is ideal for submucosal fibroids protruding into the cavity, and this falls into the category of type 0 and type 1, depending on the European Society of Endoscopic Surgeons. And the hysteroscopic resection is not ideal for very large fibroids, more than 4 to 5 centimeters, and fibroids with less than 50% protrusion into the cavity. And this is the classification proposed by the European Society of Endoscopy, in which submucosal fibroids are divided into type 0, type 1, and type 2. Type 0 is nothing but a pedunculated submucosal fibroid which completely protrudes in the cavity. And then type 1 is a fibroid with more than 50% protrusion into the cavity. And type 2 is a fibroid with less than 50% of protrusion into the cavity. And type 0 or type 1 are best dealt by hysteroscopic resection. And then type 2 is best dealt with laparoscopic route.